I would like to thank the organizing committee for inviting me here today, and I'm especially honored to deliver this topic today that transcends the traditional perception of a pharmacist as a mere dispenser. So, the pharmacist profession has seen a gradual expansion in terms of its roles, duties, and responsibilities. It was primarily product-based, which is mainly dispensing of the prescribed therapy. However, due to certain drivers of evolution such as scientific and technology advancements, and especially the evolution of national health systems and model of care, that is now focusing more on personalized, individualized medicine compared to a one-size-fits-all framework, have shifted the role of pharmacies towards being more service-based. And this is especially in the context of HIV care, where pharmacies have now transitioned into dynamic practitioners actively contributing to the welfare of people living with HIV. Now here I would like to discuss a little on the optimal treatment model, and quoting the World Health Organization that recommends multidisciplinary team, which includes a physician, pharmacist, and nurse for a better quality of care and health outcome. And also in 2021, the International AIDS Society has established the person-centered care approach, which considers the whole person rather than just focusing on the disease. And this is especially vital for our patients because we have high expectations for our patients to engage with both HIV services and antiretroviral therapy over a lifetime of changing circumstances and different pressures. Now, pharmacies, especially those that are specialized HIV pharmacies, undergo rigorous training to equip themselves with knowledge, and this is from the very basic understanding of the virus to interpretation of laboratory values. So some of the advanced trainings include postdoctorate residences, fellowship programs, and antiretroviral stewardship programs. There are also certification programs from the American Academy of HIV Medicine and also the Board of Pharmacy Specialties. Now, the literature on pharmacists' involvement and improvement in patient care is robust, and I would just like to quote here a systematic review from Ahmad et al. That is presented in the AIDS, which is published in the AIDS patient care, which demonstrated that pharmacist-led interventions and stewardship significantly reduced antiretroviral therapy-related problems. And I especially like the third point here, which stated that physicians usually accept more than 90% of the pharmacist's recommendation, which demonstrates the kind of trust and expertise of a pharmacist in HIV care. So I would like to briefly go through on the model of care for pharmacies that is located with a provider in inpatient and outpatient setting of a medical center. So some of the roles of pharmacies in inpatient or outpatient settings include going for rounds with the doctors, serving as a HIV medication steward. That includes correcting or adjusting HIV regimens, adjusting for renal or hepatic impairment, identifying and managing drug interactions, medication reconciliation, education and training, which I myself am a preceptor, opportunistic infection management, medication therapy management clinic pharmacies or MTM pharmacies, and patient counseling. Some of the added levels of care include case management or follow-up of care for specific patients, communication with the physician or outpatient provider regarding any regimen changes or review of laboratory. And we also make essential members of the HIV hospital or clinic quality improvement teams, where we offer valuable insights on implementation studies to improve any below target performance measures. Here, I would also like to show the critical role of pharmacies in HIV, especially in the aging population. As HIV treatment has advanced and people living with HIV have near to normal lifespan. However, they are still associated with multimorbidities and polypharmacy. As we can see here, a study that was published in Oxford Press, the number of different classes of non-HIV medication increases with age, as well as the number of different non-AIDS comorbidities. So here again, pharmacies play an important role for looking out for polypharmacy, drug interactions, medication reconciliations, and many other. So still in the context of our discussion, I would like to bring your attention to a real-world case scenario. Here we have a 31-year-old gentleman who works as an event planner. He was started on antiretroviral therapy, tenofovir, emtricitabine with efavirenz. This regime is still our first line. Since September 2018, he had a history of default in 2020 till 2021, and thereafter he was started on a second-line therapy, which included tenofovir, emtricitabine plus dolutegravir. And we noted that was started in August 2022. During the clinic visits, we noted that the CD4 kept declining and viral load keeps increasing. Here, patient insisted on good adherence and no missing doses. At this point in my clinic, we were employing self-report as a way to assess patient. Pill count is usually not successful. So as you can see here, the CD4 is declining and the viral load has increased to 5 logs, almost 6 logs. So this was my infectious disease consultant's dilemma. So he brought forward this to me. He said, Preethi, we are picking up patients late. How can we identify patients who are likely to have suboptimal adherence and experience virological failure? And if could engaging with a pharmacist provide new insights in patients' outcomes? So in 2010, World Health Organization developed a global strategy for HIV drug resistance prevention and assessment, which included 8 early warning indicators, of which many studies reported on-time ART drug pickup was a significant predictor of drug resistance. So this prompted us to conduct a cross-sectional study among our patients in Hospital Sungai, Buloh, Malaysia, which is also the National Referral Center in Malaysia. We have about 7,000 patients on follow-up, and we conducted this study among 691 Malaysians who are receiving antiretroviral therapy. And our primary objective here is to assess the impact of pharmacist counseling at the point of late ART refill. Now, there were 100 patients who were late for their antiretroviral refill, and all these patients were absorbed immediately into a comprehensive counseling session. So the diagram here shows that a brief methodology of what we did. All patients who were late for antiretroviral therapy were screened at the outpatient pharmacy department, and they were immediately referred to the MTM or MTAC pharmacies. And the MTAC pharmacies then conducted an enhanced adherence counseling, assessment of the patient's adherence, and we also discussed with the infectious disease team on ways to better engage the patient in care and also manage their adherence gaps. So these are some of the interventions that we did at the point of care, which is promotion of outpatient pharmacy value-added services for medication delivery. That included medication through postage service, pharmacy appointment systems, drive-through services, locker for you services, which is after office hour program, and medication collection from the nearest medication collection from a facility nearest to their home office. Then we also referred patients to peer support counselors. We also referred patients to infectious disease consultants for difficult patients with difficult issues, defaulters, and also reinforced and educated patients on the health implications of non-adherence to ART in great length and depth, and also addressed all their specific barriers. Now, what we found was interesting. We found that identifying patients at late antiretroviral refills and providing point-of-care counseling significantly increased their pharmacy refill adherence. As you can see here, before counseling with the pharmacist was 26%, and after counseling, the refill adherence was 83%. And also another notable finding was 90% of the patients came on time for their next 6 consecutive refill visits. This was also an interesting finding. We found that 97% of the patients achieved viral load suppression after receiving a counseling session with the pharmacist, compared to 76% prior counseling. So what we did was, because of the successful findings from this study, we then incorporated it into our protocol at the outpatient pharmacy department, and it became part of our SOP, where all outpatient pharmacies would screen and refer patients who are late for their antiretroviral therapy to the MTM or MTech pharmacies. And we found that this very simple, cheap, effective targeted intervention could serve as an early proxy for retention and care. We also had this tag placed in every ID clinic, doctor's room, as well as counselor and pharmacist room about the lessons learned from this study, which is a delayed medication pickup could be a sign of non-adherence. We like to say it in our clinic as it is one of the vital signs now. Also, there is also a tag on to review dispensing records and not just completely rely on self-report of the patients for a more comprehensive insight of patients' adherence. So back to the case, while patient insisted that he never missed any doses, we then showed the patient of his dispensing records, and we found there was no dispensing records from November 2022 to February 2023. So then he admitted that he missed his medication. He also scored mild depression, and he admitted that he had difficulty coming to the hospital because he had to take a few hours off from work. And here we intervened by introducing value-added services such as postage of medication, locker for you for medication collection. We also introduced him to a peer support, gave motivation and reassurance, as well as we provided a counselor's phone number if in any case he needs any help. Now, what we found 3 months later was his CD4 rised up to 306 and his viral load from 5 logs to 137. Yeah, so moving on, I think we are also well aware that the HIV care cascade in Asia Pacific is dropping from diagnosis to care to retention and suppression. The factors that are predicting delay in linkage, which include substance abuse, mental health issues, gender identity, co-infections, poverty, stigma, and medication adverse events. So I'd like to bring forward our another story from our hospital. We reviewed a review of patients who initiated antiretroviral at the National Infectious Disease of Malaysia. Hospital Sungai Buloh found that we had 10% of patients who were no longer in care after 1 year of initiation, and it was the highest default rate across the years. So to gain more insight into the barriers that are faced by these patients, we conducted enhanced adherence counseling for all our first-year patients. This is in line with the European guidelines that has also recommended for a systematic assessment for patients looking out on depression, cognitive problems, harmful alcohol or recreational drug use, and also talking about social support, disclosure, therapy-related factors and such. So enhanced adherence counseling is actually a prescribed protocol by WHO and is actually recommended to use after patients who have failed first-line therapy. However, we have tried to incorporate this in our patients, in our first-year patients. The goal here is to identify specific and potential barriers to adherence to have a more in-depth understanding of patients' situation in terms of behavioral, cognitive, emotional, socio-economic barriers to adherence. So here I've adapted the Enhanced Adherence Plan tool, which is from ICAP at Columbia University in collaboration with PEPFAR and CDC. Here I tweaked a bit the adherence plan tool by including a depression screening, PHQ depression screening for all our first-year patients. This is especially because our first line still consists of efavirenz. And I also included treatment motivation in my enhanced adherence counseling tool. This is because exploring treatment motivation often highlights reasons for non-adherence. Here I would also like to stress that pharmacies can play an important role in influencing outcomes associated with social determinants of health. So we interestingly found that 90% of the patients identified more than one barrier to adherence. So it's just not one issue, they had many issues. And the highest barrier reported was 45% due to transportation, distance, knowledge, and side effects, 35% on forgetfulness, work, and fear of disclosure, and 20% had issues with substance abuse, pill burden, physical disability, and depression. Here are some of the transcripts from the patient. I work many shifts in a day in a call center. I'm extremely stressed as I'm having dizziness. I'm still having dizziness and about half an hour after I take my pills. I could not come for my medication collection because my parents refuse to let me out of the house. They think I'm going to get drugs. I have a smartphone, but I don't know how to download and register the MyUbat application. The MyUbat application is used to register for postage of medication. I have a lot of medications to take. Occasionally, I miss my medications because I depend on my kids to pick it up from the hospital. And she's also on many other drugs. So what we did was to create a program, an exclusive program for our first-year patients that incorporated the Enhanced Adherence Counseling tool with the pharmacist. We proactively explored specific barriers that the patient must overcome. We also explored patients' mental health and substance abuse and developed individualized plans for these patients where it incorporated goals and patients' motivation as well as strategies to monitor any medication-induced symptoms. So this is the protocol that we have implemented in our first-year clinic. It's called the ID First Year Clinic Protocol. Here we have included at pre-heart counseling a retention booklet to ensure that patient is informed of all the services and how to manage certain side effects. We included a visit to see the pharmacist at the third visit and an enhanced adherence counseling at the fourth visit. And all these patients in the first year program will be retained for a year before they are transferred to the common infectious disease clinic pool. So post-implementation, we had about 120 patients for our first year. We found that 21% missed drug pickups, 17% required a drug change, and 23% had moderate to severe depression. All these specific barriers were addressed, and yay, we had a 97% retention rate for our first-year patients. So moving on is the model of care of pharmacies in community pharmacy. All right. So bringing all hands on the deck, community pharmacies also they are well positioned to provide an alternate community-based and differentiated delivery of PrEP. And this is especially since there is an urgent need in Asia and Asia and Pacific to scale up from pilots to national rollout of PrEP. This is the anticipated core components. In the interest of time, I am going to be a bit fast. So it includes counseling, testing, prescribing, dispensing at the oversight of a remote clinician. And what is postulated that pharmacy-based PrEP delivery can reduce both patient-level and provider-level barriers and help to improve HIV prevention access by reaching out to new populations at HIV risk, initiation and continuation. Pharmacies-led PrEP is already operational in the United States, and we can see we can see here that initiation and retention rates are also relatively high. And I'm delighted also to share here a PhD project by my colleague and friend Ms. Gan Yani, which is pioneering implementation of pharmacies-based HIV PrEP in Malaysia and Asia. This study has included 230 study participants in 6 study sites. Same-day initiation in collaboration with physician and PrEP clinics within 10 kilometers, and a 7-month follow-up with the pharmacist. And this is still an ongoing study, and if you're keen to know more, please drop an email as below. Also, pharmacies play a key role in clinical research. This is especially because pharmacies have a solid understanding on study design, drug therapy monitoring, and pharmacotherapy. They make ideal study coordinators and project managers. There are ambitious programs like Pharmacies as Personalized Medicine Experts that are training the next generation of pharmacies towards sophisticated concepts like pharmacogenetics and pharmacogenomics. So in conclusion, this is my final slide. I would like to emphasize that pharmacies have unlimited potential, and by harnessing their expertise and dedication, the landscape of HIV is poised for unprecedented transformation. And I would like to end my presentation by leaving you all with a question: who's on your team, and do you have a pharmacist on your team? Thank you.